What's the latest research on organ failure and septic shock in critically ill patients? Is an AI-powered lifestyle intervention as good as human coaching for diabetes prevention? Will the physician workforce be impacted by changes in H-1B visas? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners around the world. Today is Friday, October 31st, 2025. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today, I'm joined by co-host JAMA Deputy Editor Dr. Preeti Malani and a special guest, JAMA Associate Editor Dr. Chris Seymour. Together, we'll be discussing this week's content, including JAMA's latest publications featured at the European Society of Intensive Care Medicine in Munich. Hi, Preeti. Hi, Chris. Let's get started.
Hi, everyone, and happy Halloween. Chris, we're so excited to hear about the meeting papers. Can you take us through the first JAMA article from ESICM?
Hi, Linda and Preeti. Thanks for having me today. Turns out we have 3 simultaneously released papers at the European meeting, and the first one up is all about the SOFA score. Now, the SOFA score, or Sequential Organ Failure Assessment Score, has been widely adopted and used for almost 30 years to classify acute organ dysfunction during intensive care. But during that time, there's been no update for all the new treatments and organ support methods that we use. In this issue, Dr. Ranzani and many colleagues used 8 stages and a federated analysis to develop what they've called the SOFA-2 score. They used 3 million patient encounters to 1,300 ICUs in 9 countries to create a new data-driven score with both an internal and external validation. The SOFA-2 score accounts for things like high-flow nasal oxygen, new vasopressors that we might not have used 30 years ago, and modified score thresholds.
Chris, you wrote a great editorial for this article. You describe the development of the SOFA score and what SOFA-2 brings to the table.
You also talk about an accompanying article just published in JAMA Network Open from Dr. Moreno and colleagues for readers to check out. And if you want even more details on SOFA scoring, make sure to check out this week's JAMA Author Interviews podcast, where Chris hosts co-author of the SOFA-2 study, Dr. Singer. Let's hear a clip of that conversation with Dr. Singer.
Tell us how we can use SOFA-2 at the bedside. Is this something I should be telling my trainees and residents, medical students to be calculating on their patient every day? Is this really just for research? Take me through your thoughts.
I think it's a combination of things, and thankfully it can suit various functions and roles. Clearly, there's a research role, so you can use it obviously for looking at change over time, comparison between units. It's already being used in research studies, for example, looking at the impact of a drug on a short-term reduction in the SOFA score compared to standard of care treatment. I think it's also useful potentially as a clinical guide, and some hospitals do use it, looking at the daily score. So you're actually quantifying what you see at the end of the bed. The patient's deteriorating. You can actually look at the delta score, and that in itself has prognostic validity.
Let's move on to the next ESICM article. This is the Andromeda Shock 2 randomized clinical trial. These investigators from a large research network have followed up their initial Andromeda Shock trial to evaluate an optimal strategy for hemodynamic resuscitation in early septic shock. These investigators included more than 1,500 patients from 86 centers in 19 countries who were within the first 4 hours of septic shock. Patients were randomly assigned to undergo a personalized hemodynamic resuscitation protocol that targeted capillary refill time or usual care. The protocol had 2 tiers, and the second tier involved key measurements such as bedside echocardiography, pulse pressure assessment, as well as fluid responsiveness. The primary outcome was a composite of mortality, duration of vital support, and length of hospital stay assessed at 28 days and evaluated using a win ratio test. The authors concluded that the personalized protocol targeting capillary refill time improved these patient-centered outcomes in early septic shock.
Doctors Mercado and Semler provide an editorial for this article. They review the physiology of capillary refill time and delve into the significance of this measurement when assessing patients with sepsis.
And our listeners should make sure they check out the other companion piece to the Andromeda Shock 2 trial, the related JAMA research summary, for a quick and easy visual reference explaining this trial and its results.
Okay, Linda and Preeti, we can't talk about intensive care without mentioning blood gases or acute kidney injury. So that brings us to our third trial, Dr. Jung and colleagues, who have studied the effect of sodium bicarbonate infusion in patients with severe metabolic acidemia and acute kidney injury. The administration of intravenous sodium bicarbonate in situations like this remains very controversial, especially following their prior trial in very similar patients. Now, this clinical trial, BICAR ICU-2, looked at 90-day all-cause mortality in more than 600 patients in 43 French ICUs. These patients had metabolic acidemia with a blood pH less than or equal to 7.2 and moderate to severe acute kidney injury, and were randomized to either sodium bicarbonate infusion or not. And interestingly, they found that the sodium bicarb did not improve 90-day all-cause mortality.
In their editorial, Dr. Kusa-Rees and colleagues give a practical overview of this trial and what its results could mean for intensive care. They explain that this trial, quote, does not provide certainty on whether IV sodium bicarbonate therapy affects mortality, although the findings imply it can potentially delay or avoid the use of KRT in critically ill patients with severe acidemia and moderate to severe AKI, unquote.
The trial provides a great foundation for future research in this area. Chris, thanks for joining us to discuss these articles.
Thank you very much. It was great chatting, and check out these 3 new trials.
Linda, let's discuss a trial about artificial intelligence in diabetes prevention by Dr. Matthew Dacus and colleagues. They investigated using an AI-led lifestyle intervention based on the Diabetes Prevention Program for prediabetes and overweight or obesity. Participants were randomly assigned to receive the AI-powered lifestyle intervention via mobile app or a human coach-led lifestyle intervention delivered remotely. The primary outcome was a composite score consisting of hemoglobin A1C, weight loss, and physical activity goals. The authors conclude that the AI intervention was non-inferior to the human-led intervention.
Wow, this is really breaking new ground in lifestyle intervention. Let's switch and talk about the JAMA research letters from this week. Haley Sullivan and colleagues described their cohort study about stillbirth in the U.S. The investigators examined trends in stillbirth in the U.S. between 2016 and 2022 using commercial health insurance claims. They report that the stillbirth rate in U.S. commercially insured pregnant patients is higher than the 2021 Center for Disease Control and Prevention stillbirth rate. And in a separate research letter, Dr. Liu and colleagues evaluate the percentage of U.S. healthcare professionals sponsored for H-1B visas in 2024. As our listeners are aware, the H-1B visa is used to hire foreign workers for jobs that require special knowledge, such as physicians or other healthcare workers. The authors report that over 11,000 physicians were sponsored for H-1B visas in 2024. The percentage of H-1B sponsored physicians was nearly 2 times higher in rural counties compared with urban counties, and nearly 4 times higher in the highest versus lowest poverty counties. Policies that impact H-1B visas could have significant ramifications for U.S. healthcare. Specifically, large increases in H-1B application fees will disproportionately affect rural and socioeconomically disadvantaged communities.
A viewpoint by Dr. Abu Ghanima and colleague also discusses H-1B visas. The viewpoint explains how restrictions on H-1B visas could affect many physicians that fill critical care gaps, especially in rural communities. In a separate Viewpoint article, Dr. Donnelly and colleagues review less publicized legal cases that have important implications for Mifepristone regulation at the state level. And a Viewpoint by Dr. Russell and colleagues advocates for more oversight in the substance use reduction app marketplace, especially given the integration of generative AI into mobile health apps.
The JAMA review this week is focused on keratinocyte carcinoma. Dr. Wayner provides a detailed evidence-based summary of these skin cancers, which include basal cell carcinoma and cutaneous squamous cell carcinomas. JAMA Associate Editor Dr. David Seimel joins Dr. Wayner on the JAMA Clinical Reviews podcast to share more about this common cancer. It's a great podcast that is complemented with a video about shave biopsies. A quick review of this video is worth your time. Let's hear a bit from Dr. Wayner now.
Well, most clinicians learn in medical school, whether they remember or not, I remember learning this, that basal cell carcinoma looks like a pink pearly papule, right? That's what you read in the review books. And that's true, but I think it's important to remember that basal cell carcinomas have several clinical subtypes. Nodular basal cell carcinomas are the ones we think of as that pink pearly papule. So these can be shiny or sort of translucent looking. They have a smooth surface. Sometimes you see those visible blood vessels on them. But there's some other varieties as well. Superficial basal cell carcinomas are red, flat lesions, sometimes with some scale. And these really commonly get misdiagnosed by patients and by non-dermatologist clinicians as eczema, because they really do look like a stubborn spot of eczema. So a classic situation is someone says, I've been treating this eczema spot on my arm for a year, all these topical medicines from my primary care, and we just can't get it to go away. And it turns out that it's a basal cell carcinoma.
Our patient page this week is about a condition involving inflammation of the uvea. You guessed it, uveitis. It has information about symptoms, treatment, and more for patients. Deepen your statistical knowledge with JAMA's Guide to Statistics and Methods article. Dr. Little explains when and how to use pattern mixture models for missing data. And with that, there's also been a lot of rapidly developing medical news. Our outstanding JAMA medical news team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at jamamedicalnews.com or click on the link in this episode's show notes.
Thanks, Preeti, and thanks to our special guest, Dr. Chris Seymour. And thank you for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Chris Seymour, Dr. Preeti Malani, and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens, Ella Barnes, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.